Next is about the calcium imbalance as such. Before going into the calcium imbalance, very brief about the physiology of maintenance of the calcium concentration in the body. So calcium is present in the body in two forms, the ionic and non-ionic form. And as far as the acute physiological conditions like cardiac and muscular functions are concerned, it's about the ionic calcium which is important. Non-ionic calcium is in the bones, stored in the bones. And there is a continuous exchange of that ionic to the non-ionic calcium compartments, and this is regulated by the parathyroid hormone and the calcitonin. The calcitonin or calcitrol would be enhancing the calcium concentration, this ionic calcium concentration in the plasma, and reduces in the bone as such. There is a mobilization of the calcium from the bone to the serum, whereas the calciferol, it helps in absorption of the calcium from the gastrointestinal tract. Kidneys, of course, they also are one of the sources of calcitrol, which can help in resolution of the bone and hence release in the ionic calcium. So all that what we are going to discuss about the calcium imbalance is about the ionic calcium, not the non-ionic calcium. Now, ionic calcium could be reduced due to two factors, either hypocalcemia, or it can be altered either as a hypocalcemia or hypercalcemia. Hypocalcemia, the lower concentration of the calcium, can occur with a low phosphate concentration or high phosphate concentration. And of course, the parathyroid hormone abnormality. The causes for this, again, further situation could be in the low phosphate concentration. Again, there could be two forms, with the high parathyroid or the other way, normal parathyroid. Hyperthyroid conditions with the hypocalcemia can present due to vitamin D deficiency, acute diseases like pancreatitis, certain of the antiepileptic drugs like phenobarbital can result in hypocalcemia. Blood transfusions, where because you repeatedly give blood transfusion, there will be citrate, and these citrates will bind with the calcium, ionic calcium, and hence there could be hypocalcemia produced as such. Whereas a low parathyroid hormone concentration can result in can be produced due to either reduced magnesium concentration or maybe a structural diseases of parathyroid gland, either after the surgical removal or maybe any other way, a abnormality of the parathyroid gland. A high phosphate or normal phosphate conditions also can be produced due to increased parathyroid hormone levels are presented with the increased parathyroid level, and it can occur quite commonly in acute renal failure. Majority of the acute renal failure patients would have a low calcium level. Hypocalcemia is one of the complications, and that's why routinely in all cases of the acute renal failure, calcium supplement is given. Any of those diseases which result in the destruction or damage to the skeletal muscle, the abdomyolysis is an abnormality of the muscles. It can result in hypocalcemia. Tumor lysis, particularly when the patients are treated with radiation or chemotherapy, the dissolution of the tumor tissues can result in variations in the hormonal concentrations and can result in hypocalcemia. Then there is a condition called as pseudohypoparathyroidism, where temporarily the parathyroid gland may be functioning abnormally, and later it may result in a rebound hyperparathyroidism, increased parathyroid hormone levels, and that can result in hypocalcemia. Hypercalcemia is the other way. It could be produced due to abnormality of the concentration of the calcium in the plasma, which may present with either a high urinary output also, where the plasma concentration is higher and the concentration of the calcium in the urine also is higher, or a plasma concentration of the calcium could enhance if there is a renal abnormality of the kidneys, where the kidney fails to excrete the calcium. The total calcium content in the body can be increased, and particularly the adrenal mechanisms could be affected, resulting in hypercalcemia in the patients who are on regular thiazides like diuretics like furosemide for a long time, or patients who are on lithium like drugs. Lithium is having a resemblance to that of the structure, this calcium as such. Then there is a familial pathology. it can occur in the family's genetic constitution. Some families, people tend to have that, or simply consumption of excess of calcium, acquired hypocalcemia, hypercalcemia can occur. Then the hypercalcemia with the increased urinary concentration can occur due to abnormality of the bone reception changes, like where there is an abnormality of the parathyroid hormone, and again parathyroid hormone can present with the a high concentration or low concentrations, where hypercalcemia could result, and a high concentration could be primary hyperparathyroidism, where there is an abnormality of the parathyroid gland where it can enhance. Tertiary is as a result of certain drugs or treatment, the parathyroid gland could be a functioning abnormality. So, with the high concentrations. Low concentration of parathyroid hormone (PTH) could be in patients of hypercalcemia if there is a osteolytic lesion. Patients with the tumors of the bone, and particularly very specifically with the osteosarcoma, it tends to occur as such because there is a continuous resorption of the bone. Though the parathyroid hormone level may be normal or subnormal, it can occur. Or humoral is the other abnormalities, like other abnormalities, endocrine glands, or the even sexual hormone concentrations can affect the calcium level. It can result in hypercalcemia. Then endocrine pathology like hyperthyroidism or adrenal insufficiency also can result in hyperparathyroidism, though the pH level could be either normal or below normal. And aerodynamic bone diseases, particularly patients who are bedridden and where the bone doesn't get the exercise. It's quite commonly seen. Patients who are bedridden or maybe immobilized for a long duration, it can result in hypercalcemia because of the resorption of the bone. Then, in the gastrointestinal abnormalities, another cause for the hypercalcemia is that when the persons consume more of calcium, and there is an increased absorption of the calcium even. One of the common causes for the increased calcium would be consumption of excess of the calcium. Excess of the calcium as a medicine or as a therapy. And it has become a fashion now, like any middle-aged persons would have this calcium supplement, and that supplement unnecessarily can result in a hypercalcemia. Or it could be like excess of vitamin D overdose where it's given, or at times it could be vitamin D metabolism can occur in the body with the abnormal high concentration of vitamin D. Calciferol concentration could be higher. Then diseases like tuberculosis, sarcoidosis also can result in the hypercalcemia. Chronic fungal infections also can result in hypercalcemia as such. So, the causes for hyper and hypocalcemia could be many. Clinical symptoms of this hypo and hypercalcemia are quite important. From the clinical point of view, hypocalcemia is more common than hypercalcemia, and significant also, more important from the clinical point of view. Hypercalcemia is significant in the patients who are on digoxin therapy. If the patients are not on digoxin therapy, hypercalcemia may not be an emergency as such, whereas patients on digoxin therapy, if the concentration of calcium is increased, there can be sudden cardiac arrest. Other than that, there may not be. Whereas in case of the hypocalcemia, the typical clinical symptoms would be initially it could be irritability or anxiety. Later, it can result in a typical spasm, that carpopedal spasm, uh, phosphate signs, like where the muscles go into spasm, and it's also called as association sign, like the muscles of the fingers, particularly small muscles of the fingers, pharyngeal muscles, they tend to go into spasm, resulting in a position where the hands will be fingers will be flexed. This can be enhanced, or this can be seen better, or a latent hypocalcemia can be made out better if you temporarily reduce the blood flow to the area by putting a tourniquet around the shoulder. If you put a tourniquet around the arm and then wait for 1 or 2 minutes, then there could be a carpopedal spasm produced. Or in advanced stages, there could be a generalized seizures also. The same, the carpopedal spasm can result in a tetanic situation where the seizures like condition can occur. A acute fatal condition can occur if there is a laryngospasm and bronchospasm. The spasm of the skeletal muscles along with the spasm of the larynx and the bronchi muscles also can result in respiratory failure and complications can occur. And in case of cardiac pathology, it can result in a pump failure, heart failure can occur. Muscle cramps also are the common clinical symptoms in case of a hypocalcemia. Whereas hypercalcemia, initially it presents as a inability to concentrate and a need for more sleep or depression, also on psychiatric symptoms tend to occur. Hypercalcemia is often presented with the certain symptoms like depression, confusion, etc. And often they are misunderstood as psychiatric conditions. And again, this is quite common in the middle-aged women where patients are unnecessarily taking calcium. These symptoms could be presented and they are misunderstood as a psychiatric condition and they are given again some antipsychotic or antidepressant drugs quite frequently. In such a condition, rarely it can even result in a fatal complications even. Hypercalcemia tends to produce arrhythmias or bradycardia. Particularly, the risk is more if the patient is on digoxin. So, before you advise calcium, in any patient, before you advise, you have to confirm whether the patient is on digoxin supplement or not. Patients on digoxin supplement can result in acute cardiac arrest when the calcium is given in excess. So that's one of the important precautions. And particularly the risks are higher if it is given parenterally. Calcium given parenterally can result in acute cardiac arrest and the death in systole. That's very characteristic. Usually, in all other conditions, when a person dies, the heart would be in the diastolic phase, the heart would be dilated. Only in the patients with the calcium toxicity, if there is a death, and calcium toxicity with the is digoxin supplementation, the death would occur in systole. If you do a postmortem, the heart would be in a constricted situation. And of course, the muscle weakness also could be the other clinical symptoms. One of the characteristic features which you will see would be by the ECG. In the ECG, characteristically, hypocalcemia results in a prolonged QT interval, a widened QRS complex, whereas hypercalcemia presents with a shorter QT time interval. Normal QT interval is 0.36 seconds, whereas in case of hypercalcemia it could be 0.25 and hence it can become a QRS complex becomes sharper and later on it can result in arrhythmias, different sorts of arrhythmias, either and most of the times bradyarrhythmia. The gap between the QRS complex tend to increase, whereas in case of hypocalcemia, the QT interval would become higher, as good as maybe 0.48 seconds, and then it particularly there is a tendency for the blockades and bundle branch blocks can occur in later period and this ECG is quite characteristic of the calcium level assessment from the clinical point of view. Now treatment of course, whenever the patient is confirmed to be having hypocalcemia, the maximum dose would not be more than 1500 milligram per day. That's the maximum oral dose. Maximum oral dose of calcium should not be more than 1.5 grams. That's to the in very severe cases. But always it should be on a better lower level. And if the calcium raises above 10 milligram per this 100 ml, then dosage should be decreased. So suppose a patient has a hypocalcemia and you have started with the calcium supplementation and after 1 or 2 days of therapy, if it has raised up to 10 milligram, then you reduce the dose. That's the important. You are not supposed to maintain the same dose as such. Then, if at all you are giving calcitriol, that's the calcitriol is a new combination or molecule of calcium, organic molecule. It's 0.25 to zero point 0.5 microgram orally, and that along with the calcium, vitamin D also is administered in that calcitriol, and it should be administered in a smaller dose. 0.25 to zero point 0.5 micrograms is the ideal dosage for the vitamin D supplementation or vitamin D can also be given in a interval of 1 week, once in a week or so. Then the of course the another calcium supplement which is available in the market is organic calcium, cinacalcet, and it can be used in if the patient has a increased phosphorus level. This is very having a specific indication. Patients with increased phosphate level, as in case of bedridden patients, where the bone resorption occurs. Then, in such conditions, cinacalcet could be used, but it's not very regularly used. It's not that every patient could be administered the same say, calcium oxalate or calcium supplement. You have to have a choice as such. Then hypercalcemia, the best of the treatment would be hydration. You give saline, either saline or 5% glucose, or maybe give orally a sufficient quantity of water and restrict the calcium intake. That's always a better issue. Saline is always preferable if the patient has a very high concentration of hypercalcemia, and if at all there is an urgency, you have to reduce the calcium level immediately. Furosemide also is given. The Lasix, the same diuretic also can be given in a high dose to reduce the calcium level immediately. That's only in case of the emergency, not the other way. Then glucocorticoids also can help in absorption of the calcium to a certain extent, and they enhance the tubular reabsorption and reduce the tubular reabsorption also. So urinary calcium level would be raised, but this is limited to a few cases where there is a acute tetany like conditions, and you need to immediately reduce. Then glucocorticoids and furosemide are given in high doses. Calcitonin, as such hormone, is not regularly given. Only in very specific cases, there is where there is an abnormality of parathyroid hormone, a calcitonin is indicated, and the dose is 4 international units per kilogram, subcutaneous or IM, and it can be maximum dose could be 8 units as such, but it's only for specific conditions where you exactly know that there is an abnormality of the parathyroid hormone and you need to neutralize it. Then another empirical drug used is mitramycin. Mitramycin is primarily an antibiotic, but administered in a low dose of 25 micrograms per kilogram, it can reduce the calcium level in certain patients. But again, not a very popular option. The best of the option which we can manage in our levels would be the saline and maximum diuretics like furosemide and or maybe glucocorticoids. Inorganic phosphates or soda is usually prescribed in patients with the renal pathologies. Renal pathologies, calcium also is supplemented, and inorganic phosphate also is administered. Patients who have a definite known hypercalcemia, the phosphate could be administered in low doses. It's only in the specific cases of either renal failure or familial hypercalcemia. In these conditions, it's given, otherwise not. So that's about the electrolyte imbalances. Now the question would be whether these electrolyte imbalances are mentioned in Samhita or not. Uh, of course, Sushruta or Charaka might not have studied about the electrolytes, but the typical clinical symptoms produced due to the electrolyte imbalances are uh, categorized or accumulated in the chapter of Trishna. Trishna Vyadi is a fluid and electrolyte imbalance. And only thing is, instead of specifying like sodium or potassium, all the conditions are accumulated in, and where of course the causes could be the same, like shobhat bhayat kshamat vapi shokat krodhat vilanganat madhyat क्षार अम्ल लवण कटुक उष्ण रुक्ष शुष्कान्न सेवादिभिः धातुक्षय गदकर्षण वमनादि अतियोग सूर्यसंतापैः पित्तानिलौ प्रवृद्धो सौम्यान् धातुंश्च शोषयतः सौम्यान् धातुंश्च शोषयतः. There will be an abnormality of the saumya dhatus, and it results in रसवाहिनीश्च नालीः जिह्वामूलकलतालुक क्लोम्नः संशोष्य नृणां देहे कुरुतः कृष्णां महाबलौ एतौ पीतं पीतं हि जलं शोषयतस्तावतो नयाति शमम्. Krishna is often translated as only a thirst. I think it's not a only that. Krishna Vyadhi is not only that, where it results in an abnormality of the fluid and electrolyte conditions, and it can be presented as a Vataja, Pittaja, or Kaphaja. The Vataja is very typically the clinical presentation of hyponatremia, where the patient would have a dry mouth and the headache like conditions, and it often enhances. The condition would be enhanced when only water is given. It's very important. Shitabhi Adbishta Vivrdhimeti. In case of hyponatremia, you are not supposed to give only water. Along with water, you have to supplement with the these uh, electrolytes, maybe is a sodium chloride. If you do not do that, it can enhance, and that's exactly the point in case of the Vata Trishna. So obviously, Vata Trishna is a hyponatremia, whereas Pitta Trishna is a Murcha Pralapa Ruchi Bhakta Shoshaha. It's all the typical features of the hypokalemia, potassium level being reduced, and parinubhananja, there will be burning sensation. So, whereas kapha trishna is obviously the dehydration. Obviously, the dehydration conditions where the patient would be losing the water contents as such. Deha rasaja ambubho rasast rasakshayata तृष्येत दीनस्वरः प्रताम्यन् संशुष्कहृदयगलतालुः. There would be dryness of the palate, the oral cavity, and so on. So Trishna Vyadhi is the abnormality of the electrolyte conditions as such. And of course, the precautions you have to take is you are not supposed to give water alone immediately, and it should be like, if you have exposed to the sunlight, you are not supposed to consume water immediately in large quantity, and it's always should be that there has to be Ayindra Jala. Ayindra Jala is where the water is having some mineral contents that has to be administered, or it could be like panakas, different panakas which have to be administered. That's in brief about that. The last point which we discuss will be about the acidosis and alkalosis, the pH imbalances. The majority of all the biological functions of the body would be functioning normally if there is a normal pH, and that normal pH in the body, human body, is in the range of 7.35 to 7.45. That's mildly alkaline, whereas anything below 7.35 we consider as acidosis, and anything above 7.45 we consider as alkalosis. A survival of the human body is possible only when the pH is in between the 7.35 to 7.45, and beyond that range it can become fatal. And both alkalosis as well as acidosis can become fatal. So, and it's also an emergency which need to be treated. The source of the acids are the bases in the body, and maintenance of that acid-base balance is very important from the physiological point of view. Again, I will not go into the detail of physiology. Very brief. The source of the acids in the body are mainly from the consumed acid substances, and of course it's also produced, a large amount of the acid is produced by combination of carbon dioxide and water. Carbonic acid is formed, and the same carbonic acid can be broken down into hydrogen ion and bicarbonate ion, which can add to the non-volatile acid. That hydrogen ion released will be the adding to the acids as such. In addition to the acid is produced in the body during the metabolic activity. Glucose metabolism at every stage of carbon this Krebs cycle, some acid is produced, and these acids could be added. Acids also could be added to the body by consumption of the food, and all the nucleic acids that also are acidic in nature. So source of the acid is from the different sources. The alkaline sources are mainly the carbon dioxide and bicarbonate ion. Bicarbonate is the major issue. Now, if there is any change in the acid and base balance, now I will directly come to that part. The body would be trying to cope up with it by two mechanisms. One, the buffering mechanism. Buffering mechanism is the changes are reduced or changes are prevented from being going beyond control. So there is an inherent mechanism of maintaining that acid-base balance, or if at all it goes beyond that limit of the buffering, there will be compensation. Compensation is by altering the physiological functions to a certain extent it can manage. If it goes beyond these limits of the body of both buffering and compensation, that becomes a acid-base imbalance where you need to intervene. So clinical conditions of acid-base imbalances are not made to be seen immediately because body has an inherent capacity of preventing that from going beyond control, and only when it goes beyond control there is a need to intervene. And or if these basic mechanism of buffering or the next level of compensation are not functioning properly, then there would be a acid base imbalance in assets. Now those buffering mechanisms are, buffers are the first line of the defense, and the major buffer in the body is bicarbonates. Bicarbonates are the major buffers. Bicarbonates are the production produced due to the breakdown of carbonic acid. So whenever the carbon dioxide is released from the tissues after the this respiration, tissue respiration, that carbon dioxide is dissolved in water in the and whenever there is a need, it can result in the release of carbonate, bicarbonate, and hydrogen ion. A buffering mechanism would maintain the concentration of this hydrogen and bicarbonate ions in balance depending upon the requirement. If there is a tendency for the pH to be reduced, then more of bicarbonate is preserved and hydrogen ion is converted into water by combination with oxygen. If there is the other way, there is a tendency for the pH to be raised, then more of bicarbonate is released in the form of carbon dioxide in the breathed air, and it maintains that. So that's one. Then the non-bicarbonate buffers are mainly the hemoglobin, protein, and phosphates also as the buffers. In addition to that, the blood buffer system acts instantaneously, and again, as I said, it will be maintaining that hydrogen ion binding as in a balance as such. The hemoglobin buffer mechanism is actually all these are linked. This hydrogen ion, carbon dioxide, bicarbonic acid, all these are linked together along with the hemoglobin buffer system. Hemoglobin buffer system is by regulating the concentration of carbon dioxide and oxygen. See, major function of the hemoglobin is or rather the only function of the hemoglobin is to bind to the oxygen and carry it to the tissue, and at the tissue level release the oxygen, bind to carbon dioxide, bring it to the lung tissue. Now, carbon dioxide when it is brought in, it can be a source for a release of hydrogen ion or the bicarbonate ion. And it's a continuous process. This process is a continuous process, and whenever there is a need, the carbon dioxide can be released in the form of bicarbonate or the hydrogen ion can be produced as such. So, and it can having a shift of the ions. Bicarbonate ions can be shifted in case of chloride, and that's also called as a chloride shift, or hydrogen ions could be released to have that pH controlled or pH reduced when there is a need. And this mechanism is one of the important mechanism which shows immediate response. A minor changes in the pH can be neutralized immediately, and you will never know that there is a change as such. Now, like when I say minor changes in the sense, suppose when you sit and because of the pressure over the area, the buttocks area, blood flow could be reduced, and that reduced blood flow can result in accumulation of the acidic substances. Or when you do a rigorous exercise of a specific group of the muscle, it can result in release of acidic substances at that area. But immediately that is washed off as well as it is neutralized by this mechanism, and you will never know that there is a acid-base imbalance as such. Then the phosphate buffer mechanism is the next level. It's mainly containing that phosphate anion, and it's a weak acid, and it functions in the same manner. When there is a acid-base imbalance, that phosphate ion is either released or they are conserved. It doesn't affect the hydrogen ion level. See, unlike that of the hemoglobin buffer mechanism, where the hydrogen and bicarbonate both are controlled, the phosphate buffer mechanism doesn't eliminate the hydrogen ion, but it can reduce or increase the phosphate level, and hence acts as a relatively, comparatively weaker buffer, but it starts only in the next level. Suppose the hemoglobin buffer mechanism is not sufficient, then the phosphate buffer mechanism can come into the picture, or maybe at times it could be simultaneous. Uh, Now, then the next is the respiratory acid-base control mechanism. Respiratory acid-base control mechanism is the same pH hemoglobin mechanism. It can make more potent, more enhanced by regulating the respiration. When there is a need to eliminate more carbon dioxide, the rate of respiration increases, and hence the carbon dioxide is released in higher concentration. If there is a tendency for the acidosis, there is a new need to preserve the carbon dioxide, and that preservation is done by reducing the rate of respiration. So, which occurs again in a few minutes, like these changes do occur in a few minutes. So, acid-base mechanism, instantaneously it is controlled by the hemoglobin and phosphate buffer mechanism. When it goes beyond their control, the next is a respiratory control comes in, where the respiratory center comes in as such, which will regulate the rate of respiration. So if there is rate and volume of the respiration, so exchange of the air in the lungs is controlled, and whether the carbon dioxide has to be released in higher concentration or if the carbon dioxide has to be released in higher concentration, the rate of respiration increases. If the carbon dioxide has to be preserved, rate of respiration and volume of respiration would be reduced. This way, the acid-base mechanism can be controlled. This is what you do, like what you have experienced, like when you do a rigorous exercise. Temporarily, you may feel like you may have a increased rate of respiration. Later, once you take rest, the rate of respiration comes back to the normal. So this is how the acid-base mechanisms are maintained at a normal level. Do not go beyond that. The next level, even if this also is not enough, then the next part would be the renal level. That kidney would be acting as a third line of defense against the changes of pH, and it's by regulating the excretion of bicarbonate in the kidney or retention of the acidic substances in the kidney, and it has a long-term effect. Usually, the renal mechanism do not come into picture immediately. They take about hours to days for the correction, and many times the correction may continue for a quite a long period. Like suppose if you have done a rigorous exercise and have not consumed enough of water, and the rate of respiration continues to be there, next day you may have a reduced volume of urine to cope up with that the accumulated acidic substances with the retention of the bicarbonates. So this is how it's maintained, and it can continue for a longer period. So at the end, that's the end of it rather. The spontaneous regulation and compensation. So buffers with the renal control, it can be acting as a buffer as well as it can be a compensatory mechanism where the physiology is altered. And the role of kidney is mainly by the bicarbonate ions, and the bicarbonate can be filtered to a maximum extent. It can be filtered up to 99.9%, as good as like there will be virtually no bicarbonate at all. So it's very strong, whereas the bicarbonate level controlled by the respiration is limited because there is always a tendency for the diffusion, whereas renal regulation of controlling of the bicarbonate is a very potent, and it takes up in the later stages or and hence it can prevent a acid base imbalance to occur, or it also is acting through the ammonium salts. Ammonia is an acidic substance, and it contains more of hydrogen ion. Conservation of the ammonium salts also is possible. So that's about the issue, and ammonia could be bound with the phosphate and results in a secretion of the acid if there is a need for the secretion of the acid. So in brief, these are the three mechanisms: respiratory, and the blood concentration, and the renal. Renal would be coming to the last step. The hydrogen ion removal by the blood and controlling of in the concentrations in the blood is the initial state, and lungs, respiratory is the next, renal is the next level, and all these three mechanisms are interrelated. It's not that one functions independently, all of them are interrelated, and these three total systems would help in maintenance of the acid base balance in the normal situation. Now, so that's in brief about the physiology. Now, coming to the imbalances. Imbalances are mainly categorized into four categories: metabolic acidosis and metabolic alkalosis, and respiratory alkalosis and acidosis. Because for the practical clinical point of view, you need to either regulate the metabolism of these ions, or you'll have to regulate the excretion of these ions to the respirations. Respiration and the metabolism are the major sources for the acid-base imbalance, or maybe the means through which we can manage that acid-base imbalance, and that's why we categorize these imbalances into two categories, metabolic and respiratory, and then again the subcategory like acidosis where the pH gets reduced, alkalosis is where the pH is increased. Now we go one by one. The primary difference between the metabolic acidosis and the metabolic alkalosis are similarly would be, in case of a metabolic acidosis, is always related to a hydrogen carbon dioxide concentration is reduced and bicarbonate also is reduced. In metabolic alkalosis, bicarbonate as well as carbon dioxide is increased. Respiratory acidosis, carbon dioxide is increased and bicarbonate ions also are increased. Along with though the carbonate is present there, the pH is lower. Respiratory alkalosis, carbon dioxide as well as the bicarbonate ions would be reduced, and even if the carbonate ions are reduced, it results in alkalosis. That's all the basic difference. The basic difference is carbonate ions, bicarbonate ions are present in a maybe paradoxical situation. See, bicarbonates are alkaline basically, and the concentration of bicarbonate would be higher in the respiratory acidosis. Reason and more detail I'll come to that, and this has a significance in the management also. Whereas bicarbonate ions are reduced in case of alkalosis, which gives a paradoxical situation. Whereas in case of the metabolic acidosis, bicarbonate ions they follow the usual expected pathway. So that's all the important issue which has a significance in the management. Now we'll go one by one. The metabolic acidosis, it can be produced due to, very commonly what we see is the ketoacidosis, diabetic ketoacidosis, alcohol, starvation, renal pathologies, consumption of toxins, methanol, salicylates, etc. It also can result in metabolic acidosis as such. And the lactic acidosis also can occur due to a abnormality of metabolism of glucose. Glucose metabolism can result in lactic acid, or it also lactic acidosis can also be resulted due to hypoxia, tissue hypoxia. Now, the other metabolic acidosis, other than that, it also can occur in patients who have a extraordinary bicarbonate loss, like diarrhea or pancreatic condition, pancreatic damage like conditions, or certain drugs like calcium chloride or magnesium or cholestyramine, which is administered in the treatment of bile these stones, gallstones as. Renal acidosis also can be due to the renal pathology of different sorts, either proximal renal or distal tubular acidosis can occur, or hyperkalemia also can reduce. Drug-induced hyperkalemia. Hyperkalemia often is resulted in the acidosis, metabolic acidosis, which could be due to the all that trimethoprim like drugs, pentamidine, or ACE inhibitors, which are used in the treatment of hypertension. Anti-inflammatory drugs also can result in. Other than that, there could be rarely situations like ammonium chloride overdose or hyperalimentation, where consumption of ammonium salts is lesser in the body, or loss of potassium bicarbonate by, as in case of correction of ketosis, if there is extension there, it can result in this acidosis. A rarely acidosis can occur if there is a rapid administration of saline. It's also called as expansion acidosis, where due to sudden increase in the volume of circulation, the mechanism, compensation mechanism may fail and result in acidosis. These are rare. The important are mainly the gastrointestinal tract abnormalities from the clinical point of view. Symptoms of these are mainly, the first is the symptom would be hyperventilation. The rate of respiration tends to increase in case of metabolic acidosis. The myocardial contractility reduces, and the ability of the heart to contract would be reduced, and hence there would be an exercise intolerance. It also can result in a congestion in the lungs. At the same time, because of these two effects, like the rate of respiration increases as well as the myocardial contractility is reduced, there is a compensatory mechanism of the sympathetic system which results in tachycardia, and the blood pressure tends to slightly increase as such. And it may not, the persons, if they are being treated with some catecholamine like drugs, the response to the catecholamine drugs may reduce. It also can present with the CNS symptoms like disorientation, stupor, twitching, coma also, or be localized palsies could occur in case of the metabolic acidosis. And usually in a patient of metabolic acidosis, the pH is reduced at the same time, the potassium level also would be raised. That's how you confirm that. And the typical symptoms again, the same patient would have shortness of breath, coughing, and headache, sleepiness, confusion, same thing which have occasional seizures and weakness of the muscles. Diarrhea could be the other clinical symptom. Arrhythmias increase the heart rate because of the sympathetic overactivity. Nausea and vomiting could be the triggering mechanism for the metabolic acidosis also. One of the characteristic evidence of acidosis, metabolic acidosis, is the Kussmaul's breathing. The Kussmaul's breathing is a high volume breathing and continuous high volume breathing, deep breathing, which is seen, which is very characteristic of the respiratory acidosis in the initial stage. When the respiratory acidosis results in an extreme severe condition, the Kussmaul breathing changes to chain strokes breathing. Chain strokes breathing would be, the typical pattern would be initially low volume breathing, gradually there would be an increase in the volume of the breathing, then again diminishes, there is a gap, apnea. I think you can make out. Normal breathing would have a typical inspiratory and expiratory movements. In case of Kussmaul breathing, there would be a deep inspiration and deep expiration. Efforted breathing would be the feature. When the same results in a very critical situation where the carbon dioxide concentration tends to get accumulated very high, it results in a sign of respiratory failure. Chain strokes breathing is always a sign of tendency for the respiratory failure, and it's a sign of emergency. And the typical features would be there will be a gradual ascending volume of the breathing, then again descending volume of the breathing, a gap. And as the condition progresses, this gap increases, and at one stage, it may even result in a total apnea. Death also can occur. So, majority of the patients are on the deathbed. When you observe the patients on death, you will have these chain strokes breathing seen there. So, that's about one of the important clinical signs. Now, treatment for the metabolic acidosis. Again, the usual treatment approach would be, it has to be the emergency conditions to save the life of the patient. Then, wherever there is a known cause, that cause to be treated. Then, of course, the correction will be replace the whatever is lost, like any specific electrolyte is lost, it has to be corrected, or maybe correction with the sodium bicarbonate. See, sodium bicarbonate is a not necessary in case of metabolic acidosis. See, usually for correction of acidosis, we administer bicarbonate because it is one of the alternate alkalizer substances. But alkalizer substances in case of a metabolic acidosis is not required because by nature the bicarbonate level will be raised. Only in the respiratory acidosis bicarbonate is indicated, and hence it is quite important to make out whether a patient is in a respiratory or metabolic acidosis. The immediate emergency management would be intubation or maybe a ventilatory support, or if there is a cardiopulmonary resuscitation, it has to be. If there is a severe hyperkalemia, you need to have the diuretics also to reduce that hyperkalemia. Then, whenever there is a specific known cause, it has to be treated. Then there are certain issues like if the patient is having consumption of metabolic, these methanol like substances, a specific counter substance has to be given. And if there is a pathology like renal failure, hemodialysis can be done. So treatment of metabolic acidosis, the one important precaution is the emergency, it has to be treated. And the other part is you have to, the whenever there is a known to be having a fluid or electrolyte loss as a triggering factor, it has to be corrected. Provide more of oxygen. Bicarbonates are not necessary or should not be given. The usual is a fluid in a patient diabetic ketoacidosis. Now, one of the important common condition is diabetic ketoacidosis. In the diabetic ketoacidosis, water and insulin and potassium supplement has to be given. Bicarbonate or dialysis may be required if it is resulted in a renal failure or if it is accompanied with the renal failure. In such conditions, it may be required. That's about the principle of management of metabolic acidosis. The respiratory acidosis, it presents with the increased carbon dioxide concentration, and we categorize them into two: acute when it is less than 24 hours, chronic when it is more than 24 hours. Causes are particularly CNS depression, very common. Patients who are on drugs, alcohol, and so on, or patients who are on stroke, like it also can mean respiratory cirrhosis. Obesity, where because of the reduced vascularity or reduced ventilation as such. Patients with the neuromuscular disorders, because the movements of the muscle are not proper, or if there is a airway obstruction. So in all, where it results in reduced oxygen supply to the tissues, it can result in respiratory acidosis. It can occur due to the chest wall abnormalities. It can occur due to the restrictive disorders of lungs like pulmonary fibrosis, etc. Or if there is a abnormality of carbon dioxide transport in the blood, like cardiac arrest, anemia, or drugs like acetazolamide, also can result in a respiratory acidosis. Now, in compensation, of course, whenever there is a respiratory acidosis, there will be initial buffering, and in acute conditions, it results in a compensation where bicarbonate levels tend to be increased, and it compensates with the corresponding carbon dioxide concentration as such. And hence, in the initial stages, you may not see high concentration of bicarbonate in the body. But later in the chronic respiratory acidosis, there is a tendency for the renal compensation to come into the picture, which can result in a increased secretion of bicarbonate, and hence results in lower bicarbonate ions in the later stages as such. And other clinical symptoms could be there will be a center stimulation of the respiratory center, and hence there is a ventilation, hyperventilation, tachypnea could occur. If the tachypnea is not enough, it can result in a dyspnea. Patient may have a difficulty. Increased cerebral blood flow would be the other mechanism of compensation. Often the patient may have headache, or many times it may trigger the cerebrovascular accidents. And carbon dioxide narcosis, later it can result in symptoms like disorientation, confusion, lethargy, and so on, or it can result in coma or at times even death also. Tachycardia and bounding pulse are the other common features. The periphery would be warm and flushed, though the patient may be in an unconscious condition. Unlike other shocks, the periphery would be warm as such. So that's the basic difference between the metabolic acidosis and respiratory acidosis as such. It's same thing presented in a picture manner. Management is primarily whenever there is a known pathological process like a mechanical obstruction or maybe a reduced respiratory volume, it has to be compensated, and it always should be compensated with a ventilation where the increased carbon dioxide concentration should be eliminated. Now, this is one of the very problematic issue. When you use a ventilator, the ventilator would be helping in pushing the oxygen in, but carbon dioxide excretion may not be facilitated to the same extent. And you need to keep that open so that the carbon dioxide also is excreted properly. Then alkalization is the other way. But alkalization is mainly by soda bicarbonate. Sodium bicarbonate is the usual prescribed drug in case of respiratory acidosis. Then respiratory stimulant drugs can be given. Respiratory stimulants we have already discussed earlier. Now stimulants like very common is medroxyprogesterone, or even theophylline could be administered to a certain extent. It just to keep the respiration on, and oxygen therapy is the other way. Ventilatory support, if the volume of the breathing is lesser, then ventilatory support is required in case of respiratory acidosis. So that's about the principle of respiratory acidosis. Comparatively, metabolic alkalosis is less common. We may not see many patients of alkalosis, whereas metabolic acidosis and respiratory acidosis are more commonly seen. Now, causes for the metabolic alkalosis could be excess of alkali administration, or milk alkali syndrome is another very common condition, particularly in those days where antacids were being given, and patients who are consumption of antacid for a long duration continuously in high doses can result in loss of acidic substances from the stomach, and it can result in what we call as milk alkali syndrome. And in that patients, there will be a tendency for the hypercalcemia. Patients with severe vomiting and gastric aspirate continuously on rice tube can result in metabolic alkalosis, or patients who have specific diseases and renal origin also, diuretics or maybe the hypercalcemia also can result in metabolic alkalosis in conditions as such. Or they again, the renal pathologies again can be categorized into chloride responsive alkalosis or chloride resistant alkalosis. This is another way of going into the detail of respiratory metabolic alkalosis. May not be in the routine practice. This may not be of significant in the routine practice, but if we have confirmed the metabolic alkalosis, you have to assess the urinary chloride level. And if the urinary chloride level is less than 15 milliequivalents, then it's considered as chloride responsive alkalosis. And if it is more than 25 milliequivalents, it's considered as chloride resistant alkalosis, and this would have a significance in the management. Now, the clinical symptoms could be: one is due to the myocardial contractility being reduced, the blood pressure tends to be reduced. It can result in arrhythmia. Reduced cerebral blood flow can result in the confusion, mental symptoms, neuromuscular pathologies can occur, and hyperventilation also can result in lung congestion. There could be lung congestion as such, could be the issue. Treatment: potassium chloride supplement should be given to reduce the potassium depletion. That would be one of the first step to cope up with the metabolic alkalosis. Then potassium sparing diuretics also are given, and usually metabolic alkalosis is tolerated better and may not result in very serious conditions rarely, as it's comparatively metabolic alkalosis is less common. And then the respiratory alkalosis, again compared less common, it can present with the stimulation, central nervous system stimulation, could be produced due to central nervous stimulation like anxiety, fever, and so on, due to rapid breathing in that condition. Or hypoxia can also result in alkalosis, like patients who are on high altitudes, hypotension, and other conditions. Drugs and hormones, pregnancy, salicylates also can result in alkalosis, particularly salicylates, very well known in children. The Rees syndrome produced due to toxicity of salicylates. It is primarily a respiratory alkalosis, which can be quite critical. Then the stimulation of the receptors like hemothorax, clear chest, and so on. In that condition, because the rate of respiration increases, it can result in alkalosis. And the other conditions like hepatic failure, patients who are on ventilation are exposed to the heat quite significantly. In the heat stroke, there is a tendency for alkalosis. Clinical symptoms would be characteristically tingling sensation, tetany, or neuromuscular pathologies like, and the cerebral blood flow would be reduced, and hence the patient would have something like a giddiness, confusion, and so on. And arrhythmias are well known presentation. The other potassium level tends to be reduced, as well as the phosphate level also would be reduced. The serum calcium level also tends to be reduced. Now, in patients who are in critical ill, it could be presented as quite common conditions, and it could be even due to hyperventilation as such. Again, we will not go into these greater contraction alkalosis. It's only that the bicarbonate ion is lesser, where the volume is lesser. It can be categorized into two, where the patient may have a total volume of the circulation is lesser or volume is more. Patients who are on diuretics, they tend to develop contraction alkalosis. Or this, of course, we can just skip off this as such. Management of respiratory alkalosis is you need to ensure that the oxygen supply is sufficient, and a controlled ventilation is the major source as such, major mechanism. IV fluids could be administered in respiratory alkalosis. Primarily, it's correcting about the respiratory alkalosis itself, which can be life-threatening. So you need to give some acidic substance, usually ammoniacal substances, and saline is given. Ensure that the patient's ventilation is maintained. This is about the respiratory acidosis as such. Uh, right. That's about respiratory acidosis and alkalosis. We conclude at this level today. If there is a need, we can maybe continue in the next schedule.